All right, we're going to be talking about thalassemia. So your red blood cells need hemoglobin, and hemoglobin is comprised of 2 alpha chains and 2 beta chains. So for normal adult hemoglobin, HbA. And in thalassemia, you have a genetic defect which messes up the production of those chains. So in alpha thalassemia, the problem is you don't have enough alpha chains, and beta, not enough beta. And so the effect in the blood is you get too many of the other type of chain. So these unpaired chains mess up and damage red blood cells, and that leads to anemia. Now, interestingly, thalassemia doesn't necessarily cause iron deficiency. What actually happens is you don't have, you have enough iron, but you can't use it properly because you can't make the right chains for it. So you're not iron deficient, you're red blood cell defective is a good way of thinking about it. So ferritin, iron, and TIBC. So that's the total iron binding capacity. That's how bad you want it. How much do you want iron? And if you have a lot, then it's going to be low. So in a thalassemia, it's going to be pretty low or normal because you have too much or normal amount and you don't need to grab any more. Ferritin is going to be stored in the body like the tissue, and that's going to be high. And iron floating around the blood, that's also high or normal. And iron deficiency, it'll be opposite, like low serum, low ferritin, but high capacity for binding because we want that. So why do people with thalassemia look anemic? Even though they have iron, the hemoglobin doesn't work properly, and so you get the pale skin, you become tired, you have the spleen enlargement because you're trying to filter out the bad red blood cells. So that spleen is where that occurs, so it gets big. So mild cases, minor thalassemia, no treatments needed. Severe cases, major thalassemia, need regular blood transfusions. Transfusions because your blood is so damaged because of the dysfunctional alpha beta chains. Okay, so thalassemia is not iron deficiency anemia, it's a genetic problem. So let's actually go and do a practice question here. So looking at this one right here, it's a heme question. A 5-year-old boy of Mediterranean descent has fatigue and pallor. His growth has been normal, but his parents report that he tires easily, so fatigue, and compared to his peers, physical examination shows hepatosplenomegaly. A complete blood count shows microcytic with low mean corpuscle volume. Increased red blood cell distribution width, and peripheral smear shows target cells and nucleated red blood cell precursors. All right, and electrophoresis reveals decreased hemoglobin A and increased F. All right, so which lab finding is most likely to be seen? The answer, normal to elevated serum iron with increased ferritin levels. So let's talk about this. We got microcytic anemia, target cells, nucleated red blood cells, and increased hemoglobin F. That makes us think of beta thalassemia major. So in this, we have a mutation of the HBB gene, which leads to absent or reduced beta globulin chain synthesis. And that means we have an excess of alpha globulins, which precipitate inside the red blood cells, which causes membrane damage and effective erythropoiesis and extravascular hemolysis. So that's destruction of the red blood cells causing the hepatosplenomegaly. Causes hypochromic microcytic anemia, and even though you have that iron, it's just not binding well. Erythroid hyperplasia and extramedullary hematopoiesis, and the body compensates by increasing the amount of hemoglobin F, alpha 2, beta, gamma 2, since no beta chains are needed for that. So that's why we have F instead in a beta thalassemia. And microcytic anemia, so the MCV is going to be less than 80. Target cells are going to be shown with your beta thalassemia. And elevated reticulocytes, the marrow response to anemia is to make more reticulocytes. And iron overload causes a decreased TIBC and increased everything else because there's iron stored in the macrophages in the liver. Let's look at the other ones. Normal elevated serum with increased, that's correct. Decreased serum and increased TIBC. So decreased, that'd be an iron deficiency anemia, and that's not the case for the thalassemia. Increased osmotic fragility and acidified glycerol lysis test. So that would be hereditary spherocytosis. That's whenever the red blood cell membrane proteins like spectrin and incretin are disordered. And so that's not going to be our answer here. So D, presence of hemoglobin S on the hemoglobin electrophoresis. That'd be sickle cell. And I'm trying to think of any other high yield topics. Decreased erythrocyte G6PD enzyme. So that's when you have too much oxidative stress. So fava beans and infections and drugs will cause bite cells in the Heinz bodies, and that's not seen in the beta thalassemia. We see the target cells instead. So if this is helpful, go ahead and like and subscribe.